Everyone, we're so glad to be here. I'm speaking for my other panelists too, who I know are excited and thankful to be here. I am Cara Coleman, and as Susan said, I'm with the National Office of Family Voices. I'm located in Virginia. And I thought Susan has asked each of us to do our own little bio intro, and I thought I would start and sort of just give you myself in a few different hats. I'm going to talk first about the hats behind me because some people are looking at those going, what in the world are those things? Those are my old swim caps. And as you can see, they're kind of old and decrepit. I swam at Notre Dame, and that is, memorializing them there. So that is one hat that was many moons ago that I'm constantly chasing, trying to relive those glory days. But I bring that up, to clarify what's behind me, but also just to say that notion of partnership that Jane Elizabeth, talked about before, and team really, is in my gut and core in all that I am as a person and all that I do in my work and promoting partnership. So moving from that swim cap hat to the hat at Family Voices National, I've been with this organization for about 5 years. I've done a lot of program work. For example, I've worked all now 5 years of the Children with Medical Complexity CoINN. In the last year, though, I moved to the role of Director of Policy and Advocacy. Family Voices National, does projects and programs on a national level, and we also have the network of all 59 of the Family to Family Health Information Centers. So that's in all 50 states, DC, 5 territories, and 3 tribal groups. So I'm trying at the federal level to do some different policy initiatives and advocacy for them. And then my final hat that's really important that I bring every day and really drives what I do professionally is that I'm a mom of 4. My second child, Justice Hope, was born with multiple disabilities and medical complexity. Unfortunately, Justice passed away 5 years ago, but she drives every single thing I do professionally and personally, and is here with us, I'd like to say today, I guess. Drew, are you able to, perfect. All right. So what I'm going to do is start us off just with kind of an overview to the CoINN. And then I'm going to pass around and have each of the panelists present, and then we'll kind of moderate, and we look forward to having a discussion with you at the end. So as you can see, because we're in health, we love those acronyms, and I've already moved right away into the acronym of the CoINN, and you'll see why as you see the words here, because this is far too many words to describe what is really an amazing collaborative partnership. There are many CoINNs, Collaborative Improvement and Innovation Network. This one is specifically to advance the care for children with medical complexity. It was the first of its kind for children with medical complexity. It also was really the first one of all of the CoINNs, like for example, there's lead paint, there's early intervention. I don't even remember all the titles. I believe there's been 12 to 15 in total CoINNs. Many of them have always been sort of multi-state ones, but this is the first one that required family leadership and family partnership. And it's also the first one, as you can see, looking here at the shared goals, it's the first one that really wanted the state teams to have quality improvement, not just on the clinical delivery of care, but looking at improving the quality of life for children with medical complexity, as well as the well-being of their families. So really new and innovative ways to advance the care of children with medical complexity. This in total, it was going to be 4 years, starting in 2017 to 2021. We're now in an extra sort of bump 5th year to do dissemination just like this, sharing the learnings. And it is funded by the Maternal and Child Health Bureau. As I said, there's 10 state teams, and then there's different collaborative partners like Family Voices, AMCHIP, American Academy of Pediatrics, and there's also a National Advisory Committee, and you'll hear from Dr. Renee Churchy later, who's on our NAC. And if you could just click, Drew, to the animation, I'll share with you what the 10 state teams were. So it's lovely Alabama, Colorado, Indiana, Kentucky, Massachusetts, Minnesota, Oregon, Texas, Washington, and Wisconsin. And one last thing I'd like to say sort of about the CoINN is it's neat to see and look at it in this map, I think, really look at the depth and breadth and think about the differences between each state. Within a state, there's regional, cultural, geographic, all kinds of differences. And that's true then when you're working as 10 different state teams. And I think that something really unique about this CoINN format is that each internal state team is required to be multidisciplinary, and they very much were. Team Alabama is CRS, and also, the clinics and Family Voice of Alabama, representing, every walk of life and person and professional that loves and touches and cares for children with medical complexity. But what's something really unique as well about this CoIIN is that we really work not just multidisciplinary within each of the state teams, but across all 10 state teams. So, in the last half of the CoIIN, I'd say we almost learned and grew more from sharing across states, especially during COVID. What's going on? How are you doing this? And it just expanded the networking potential. Next slide, please. So just pause real quick to say, what do we mean when we're saying children with medical complexity? This is a very common definition that came out in 2016. There's lots of variations of it, but this is sort of the base definition of medical complexity that we worked with within it. Each team had maybe some different definitions. For example, Washington was only looking at that. They had special permission to look right out of the NICU in that transition time. But these are kids, with multiple significant chronic health problems that have, functional limitations and high healthcare need or utilization, and then there's some type of medical technology. Next slide, please. So here, what I'd like to do is just to, I've given you this overview of the CoIIN as a large, massive behemoth, right, of this, network, right? And then I want to focus down here a little bit in, so how were families involved in the CoIIN? Really, the better question is, how were families not involved in the CoIIN? And I don't think that they weren't touching, any aspect of really anything in it. We were at the leadership level, at the network level, and then within each state team. At the national level, it was myself and a few other staff members from Family Voices National that were working with the other collaborative partners, the Boston University leadership team, and then also with each state teams. I also collected all of the family leaders from each of the state teams, regularly meeting, sharing ideas, and also moving different things forward. One other thing to really note about the national leadership level is that the co-primary investigator of the entire CoIIN is a parent of a child with medical complexity herself. So she had that sort of dual role, really bringing in that personal lived experience that drives so much of our excellent work and professional expertise. At the network level, there were family leaders either from the national level or from state teams that were a part of all the different work groups. And the work groups that were involved were often, organizing the convenings, the conferences that happened every year in the CoIIN, or the one I'm going to focus on in a second is the measurement work group. There was also some involved in evaluation. And then, we were involved we had specialized affinity groups for family partnership, or like I co-led the care coordinators affinity group. So we were just involved in every aspect, and that really grew over time more. Sometimes things were separate for family partnership, and then we worked to make sure that if we're talking about measurement, there's family included. If we're talking about care coordination, families are leading and doing the same. And then at the state team level, family leaders served all kinds of different roles, either on the core group team of each state team or leading work groups of the core group. They were advisory members, they were interviewing, they were conducting needs assessment. And then we also were using the tool that I think you guys have really become familiar with in Alabama and are really a wonderful champion of it, is the Family Engagement and Systems Assessment tool. That is a tool funded by the Packard Foundation that Family Voices created to really kind of assess where teams or states are in terms of family engagement, and then how to move, take that assessment and the learnings and move it forward in an action plan to really enhance family engagement. Next slide, please. So focus down with me a little bit more into measurement. I'm just going to talk briefly about, just sort of one of the really great examples of what the family leadership and involvement at all levels in the CoIIN was able to accomplish. With that focus on the goal of improving quality of life and well-being, it became very clear to leadership up front that, as we looked, I was a part of the measurement work group that was looking at developing from multiple sources, what are the quantitative measures that are going to be used across all 10 state teams. And as we were trying to look at some and come up with what are we going to use for quality of life and well-being, myself and then other family leaders kind of chimed in and said, these are just not really great measures of quality of life. And the way we as family members and professional family leaders think of quality of life and well-being. And so we kind of pivoted a little bit. We used some quantitative measures, and then it became clear that we needed to talk about this more. And so we formed another work group, sort of a sub-work group of the measurement work group that looked at, kind of defining what does quality of life and well-being mean to families of children with medical complexity, and what are some qualitative measures that we can come up to and create that will gather more information on what this really means and how we can measure it and how we're advancing and working on it. So I led that work group, and I remember very vividly, I believe Maureen was on a lot of that work group stuff too. I remember very vividly when we were, the first session when we called it spitballing out, like what does quality of life and well-being mean? The first answers that were repeated then multiply was that it means whole person, whole child, and whole family, and really coming from that perspective. So after we formulated all these measures, we then each state team held focus groups. Next slide, please. Using these qualitative measures. And there's a lot of themes. This is a slide, I guess, actually, sorry, isn't the greatest to look at, but that's because I have a graphic recording example to show you on the next slide that'll give you some better ideas. But, as the questions that we developed in this focus group work group really helped pull out something that Kathy Caldwell alluded to earlier of, making those shared plans of care, reflective of clinical goals, but also the unmet needs of families and the other sorts of goals, like the life goals, any social supports, quality of life, well-being measures and stuff, and getting both of those into the shared plan of care and integrated into how care is delivered and cared for children with medical complexity. So these themes here sort of show a lot of that families need help getting access, especially we know this is true right in during COVID, everything's exacerbated even more, and the access to social and other community-based supports around housing and food and other things and mental health are really, really important. But also what came out too was some of these, the lower themes there around improving, education and disability awareness that was referred to earlier, that, disability really matters. It's natural. And there was a lot that was expressed by, multiple states and families in these focus groups saying, we're just not accepted. We're isolated. We're put aside. We're separate. And that's true in the community and social, but that's often true in how care is delivered to us as well, too. There's still sort of this medical model of disability, and how do we get everything integrated and coming together? Next slide, please. So this side, this is a done graphic reporting from one of the CoINN convenings and discussions we had. This is the October 2021, where we were really presenting on what are some of the findings of, coming out of these focus groups. And I think if you could go to the first illustration or animation, sorry. So this is this, and then can you do the next one as well too, please, Drew? These two, I think, are really connected to, those early themes at the top of the last slide that we're talking about, unmet needs in the community and access to social supports and other types of supports and services, but also interlaced in here with communication. How do we communicate those needs to our fellow friends and family members in the community, but also how do we communicate those to the care team? And who are the partners in the care team? And then you can see specifically there the note of people listening to them. That theme of communication and listening and truly being heard came up throughout. Next animation, please. And then, of course, the second set of focus groups was during COVID. So there was a lot of discussion of, the existing cracks and gaps pre-COVID are now these massive chasms, and what do we do with them, and how do we take from them and learn? Families are, as you all well know, more isolated. There's more fear. There's lack of access to, key medicines and housing and all kinds of things. But telehealth provides an opportunity. And so within the CoIIN, we looked at how can we shift and pivot with the opportunities in telehealth to be able to enhance the relationship and communication and advance the care for kids with medical complexity. And the last animation hones in here, thanks, Drew, on the middle of what many of us sort of themed. We were hearing that sort of the need for focusing on the whole child. Care is not just of the medical care only in the clinical care, but there's the whole child. Are they going to school? Are they happy? What matters most to them? What matters most to the family? What do they need? How do they get that all together? And what we started really hearing too is that the principles of palliative care and primary palliative care, the difference between the two is that, palliative care is delivered by clinicians that are trained as palliative care providers. There is another unmet need named in and of itself. But there are principles of palliative care that are this quality of life and whole child approach to the delivery of care that can be taught and utilized in the care of children with medical complexity by their primary care providers or by other members of the care team that can help make that shared plan of care and the care coordination more holistic and covering and looking at things in an integrated way that, will really change sort of the way that care is delivered, the way the care is received, and then also as a side note too, sort of how the delivery of care experience is for those providers delivering care and making sure that they aren't burning out and feeling like none of this is working, that it's fulfilling for them as well. And that gets to the last part here of, you can see the little illustration within the massive illustration of feels like home. That's sort of looking at a child as a whole person and a whole family as sort of the guiding post for how we advance care really came out clearly. And we worked hard year after year and to build on that within the CoIIN to have that go forward. So I think those are all my slides. Hopefully you could follow my quick overview and then shining that flashlight down onto one example of how family leadership within the CoIIN helped the CoIIN flex and respond to, the charge of the goals and ensuring that those were really driven by families and meeting the needs and finding the data that really would advance care, not data that would just sit on a shelf somewhere. So with that, I will stop talking and I will pass it to our first panelist. So I'm going to take the baton from where I am in Virginia, and I am going to pass it to the wonderful Maureen Benscooter, who is in Texas. So she is presenting to you today about really wonderful things that happen when family leadership, another example of measurement, but hers is a little different direction, and the role that family leaders played in Team Texas with measurement outcomes. Maureen.
Great, thank you so much, Cara. I'm so happy to be here today. And in the next 15 minutes, you're going to hear some of the similar themes that Cara just brought out about the whole child, hopes and dreams, and measuring what matters. So thanks for that, that great setup, Cara. I am Maureen Benscooter, and I'm a family leader in the Texas CoINN. I'm also currently a medical complexity consultant for Texas Parent to Parent, and I'm also a retired internal medicine physician. I've advocated for people with special needs here in Texas at both the local and state level. But, as Cara said, most importantly, I am the mother of George, who is a 20-year-old with medical complexity. And over the next few minutes, I'm happy to share with you just one of the achievements of our huge behemoth of the CoINN project here in Texas, and that is outcome measures that are created by, designed by families. So next slide, please, Drew. I just want to give you a little framework for the CoINN project in Texas. The clinic site for the CoINN is the Comprehensive Care Clinic at Dell Medical Center in Austin, which is a general pediatric clinic for children with medical complexity. It is not a subspecialty clinic. Among the many innovations of our CoINN project, which also included care coordination improvements, alternative payment models, an app development, and on and on. But among those, what came to the fore and really has culminated and is flowering in this last 5th year is a reimagined model for well child visits, and that is currently in the pilot, or as we like to say, the pre-pilot phase. Clinic families in Texas participated in the CoINN through our family work group, which was formed specifically for the CoINN. And as this new model for well child visits was developing over the last few years, the work group was charged with designing outcome measures to test the innovations of the well child visit, especially around care coordination and use of the new app. The outcome measures were in the form of a pre-visit and a post-visit survey. So they were survey measures. And I just have to give a shout out before I go on to one of our family members in the work group. She said at one of our early meetings, she was objecting to the name of the project with well child visit. And she said, if our children were well, we wouldn't be at this clinic. And so we changed the name at her suggestion to the whole child visit. And that's the name of our pilot project. And then secondly, the next shout out is to the young man on the right-hand side of the screen here, who is my son, George, at a Special Olympics event. And whenever I speak, I just have to show you one picture of him so you get a little bit of our family background. Next slide, please, Drew. In Texas, and specifically here in Austin, we were so fortunate to have the collaboration of the Value Institute for Health and Care as we were going about the task of designing outcome measures. The Value Institute is a collaboration between a medical school and a business school, the Dell Medical School and the Macomb School of Business at the University of Texas. And the Institute was just so generous in their time and talent in working with, as my little diagram shows, with the Comprehensive Care Clinic and with the family work group, and have become really integral to our project as it goes on. The Value Institute is led by Dr. Elizabeth Teesberg and Scott Wallace, and they have joined in personally on so many of our work group meetings and clinic meetings, both in Texas and in the country and in the world. Their tagline is making healthcare about health. What else can I say about them? They really helped us understand about how to develop outcomes, how to think about outcome measures that matter to families. And they helped us understand that when families define the outcomes, the whole healthcare system achieves greater value by focusing on what really matters. Outcomes that matter lead to greater value, and parents know what matters. A key concept in achieving greater value in healthcare is having the right outcome measures. And the Value Institute helped us think about outcomes really differently, some of which Cara alluded to a few minutes ago. But one of the ones I loved, they said, think about it like this. What if outcome measures asked, how are we doing, instead of how is the clinic doing? How are we, the families and our children, doing? And not whether the parking was adequate and your wait in the waiting room wasn't too long. This simple question, were you helped today? Were you helped by your encounter? What brings you joy? What brings your child joy? What obstacles are in the way of achieving that joy that your healthcare team can help remove? And especially for children with medical complexity, what are your hopes and dreams? Our colleagues at the Value Institute showed us that transforming the way we approach outcome measures raises aspirations. Think of those hopes and dreams. When's the last time a physician asked you about your hopes and dreams? Raises aspirations and can drive improvements in healthcare. So there's a lot riding on the back of of having the right outcome measures. So with all that background in health, next slide, please, Drew. What did our family work group actually end up with? What was our creation? So we had a pre-survey and a post-survey that, as I said, are currently in the pilot stage. And I'm just going to, without sharing the survey specifically, group our measures into 3 categories here: plan of care, medical home, and caregiver well-being. And you might look at those and say to yourself, well, those don't look too different to me from outcome measures that we've seen many times before. But I'd like to take you through the details of what our survey is actually getting to and the questions we ask. And I think you'll see what a difference it makes to have families design the outcome measures. So looking at plan of care, we didn't want to just ask, do you have a plan of care? But our families wanted to know and specifically ask, is that plan of care useful to you? Is it just some paper that you have to sign off on periodically with your physician's office and your Medicaid provider and your nursing provider? Or are they documents that are actually useful that you can refer to? Could you easily access your plan of care? Do you know where it is, and can you get to it easily? Do you have an electronic copy of it in your phone? Was your plan of care updated regularly? Our families referred to, being seen in clinics outside of our primary care clinics where, they had medication lists that were years out of date. So is the plan of care updated? And who is in charge of updating it? And this was the most important to our families. Did having that plan of care decrease your caregiver workload instead of just adding to your tasks? Did you leave that whole child visit with less on your to-do list or more? Did you, we've all left appointments where the family, in this case the parent, has a long list of subspecialists to make appointments with, and labs to get ordered, and x-rays to do, and plans to make. And so the parent comes out loaded down with more work. And our family work group felt that a plan of care that's functioning well divides the work among the team members present at that whole child visit and decreases the burden on the caregiver or the parent. Considering medical home as an outcome, we wanted to ask in our family work group, not just can you identify a medical home where your care is coordinated and where you have a primary care provider, but we really wanted to get down into the relationship between that medical home and those providers and your family and child. So we asked questions such as getting to whether the providers have a real sense of your child. And this question specifically was very important to our families. Does your provider speak directly to your child and include them in the conversation? And remember, in this clinic, many of the children are neurologically involved, and communication with them can be different or a little time consuming. But our families really felt that a care provider team that knows your child and wants to know your child will directly engage your child at every visit. We would ask not just what calms your child before a procedure, because that's a pretty common question, but how about what makes your child laugh? And what are they doing outside of school? What are they doing in school? What does the whole family like to do together? And again, what gives your child joy? What are your hopes and dreams for your child? So a medical home is way more than just being able to identify a primary care provider and a place where you get care coordination. It's where people know and are interested in your child as an individual. And then the final area under caregiver well-being, which Cara alluded to and is so important in measuring as it affects the health outcomes of our children so profoundly. And I don't think I'm just speaking for myself when I think many of us are familiar with having a medical appointment and being given a mental health questionnaire or some kind of a depression inventory. But for caregivers with medically complex children, those types of assessments were just inadequate. We talked about in our family work group, we are taking care of very sick children with inadequate supports during a pandemic. Yes, we are stressed, anxious, and depressed. Give us the checklist. Check, 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 all of it. So we wanted to get, we felt like those kind of questionnaires are superficial, and we wanted to really get to to measuring whether your interaction with the clinic decreased your feelings of stress and anxiety. Like, did you go into that whole child visit with this level of stress, and did you come out with it just a little bit lower? That we felt like that was the outcome that we wanted to measure. Did your interaction with the clinic today at this visit allow you to leave feeling a little calmer? Did you feel like your life was a little less chaotic? Did we help you? And for whatever reason that is, maybe it was that you were being heard, maybe it's you got some rent assistance, maybe you had an answer to a question, to a clinical question, but whatever it was, however you got there, we feel like it's really important that you feel less stressed coming out of an appointment, a whole child visit at your medical home, rather than more. So that's a simplification of how our family work group got to what mattered most, and some of how we measured it and what the content was. But let me go to my next slide, please, Drew. And I just want to share with you some of the bumps in the road we've encountered and lessons learned. So this was a new enterprise to all of us. I was not the only family work group member who had really not given much thought to outcome measures and how to design them. So it was a learning process. And again, the Value Institute was a great partner all along the way. But we are running into some real world challenges now as we go live with our surveys in the pilot and actually start administering them as we launch the whole child visits. And as we try to influence policymakers, and as we try to get parent-designed outcome measures incorporated into assessment tools with our partners. So the first one, the partner is not we want to be partners, not advisors when it comes to designing outcome measures. And this one is sneaky. It's just a sneaky little dude, because as we are trying to improve the usability of our surveys, we keep running the risk of backsliding into becoming advisors rather than partners. And on the family work group, we firmly believe that if our surveys get rewritten by clinic staff, even if they are trying to keep to the spirit of the outcomes we defined, then in the end, we weren't really equal partners. And all of us involved, the clinic and the families, are working to keep our guard up against that happening. We keep reminding one another that being an advisor rather than a partner reduces our authority to make and influence decisions. And when it comes to healthcare transformation, we want families to be influencers and decision makers. The next item, the length of the survey. So we had a lot of great ideas in the family work group for the outcome measures, and the survey got a little long. So it's not the content, but it's the length of the surveys that keeps coming under fire. Changes mainly have to do with trying to shorten the surveys, and also, the clinic staff being mindful of survey fatigue among families. But we are working together to come up with some innovations, like pushing survey questions out a few at a time through the app without diminishing the quality of the survey as it came from the family work group. The next item, agreeing on what matters most. Because our project site is a general pediatric practice, we have patients with every form of medical complexity that you can imagine. And within the work group, we've just always had to keep our eye on the prize of common experiences we shared and not the particular situation of our own child. And that could be a challenge, as it always is when you're working in a leadership capacity and representing all the families in a setting. Segmentation. Well, speaking of our policymaker collaborators, our policymaking colleagues often remind us that in order to improve value, it is necessary to care for patients in homogeneous sets, because you can, of course, achieve some efficiencies by applying a common set of outcome measures to every patient in that segment. I was at a meeting just last week with one of our colleagues, and he said with some frustration, children with medical complexity are so heterogeneous. And I was like, yep, we sure are, that's us. The Value Institute was really helpful here, again, by helping us thinking about grouping by shared needs rather than by, and they don't use the term segmentation, and I love the term shared needs. So instead of, grouping by a specific diagnosis or a specialty clinic or an organ system, grouping by needs such as ventilatory requirements or a certain level of neuromuscular involvement, but using groupings by shared needs to achieve some of those efficiencies. Oh, and then there's cost. So it's hard to have a conversation about improving value in healthcare without addressing money. Our family work group was not specifically asked to consider cost in our outcome measures, but during our conversations especially about shared plans of care and care coordinations, it was clear, for instance, that unreimbursed services for care coordination could lead to provider burnout and fatigue, especially during the pandemic. And their fatigue and burnout could directly impact our children's health outcomes. So we were aware of the impact of cost without having to address it in our outcome measures. And I just want to say I am glad I'm not the person who has to do outcome measures regarding cost. But I do want to say one more thing about that, because it's so important in improving value, corralling costs and keeping a lid on them. And so I want to share another learning from the Value Institute. And this is a direct quote that I found very powerful. Reducing spending is important, but not sufficient to improve value. Paying less for care that doesn't improve outcomes is not value. Rationing care is not value. The outcomes for the person being served must improve to create value. It's all about the outcomes. And I just want to add to that in the highly specialized world of children with medical complexity, what the team in Texas, the CoINN team in Texas, has come to learn is that families are in the best position to know the outcomes that matter for their child and should always be the drivers in designing those outcomes. And that's it for my comments. My last slide, Drew, is just a couple of resources. If you'd like to learn more about the fascinating and innovative work of Dr. Elizabeth Teisberg and the Value Institute, there's a couple of resources listed there. Thank you so much for your attention, and I hope we get some questions later on, and I'd be happy to answer them. And I'm going to hand it back to you, Cara.
All right, thanks, Maureen. Even though I've heard you speak and work with you for so many years, every time I write down new notes and all that, and I won't take you on my own poorly drawn, oh my gosh, I'm forgetting the name of what Ellen is doing here, the Converse sketch, right? I have my own Converse sketch, not as pretty, but you did such a great job of really showing us, and weaving through, often we say, well, that you were very particular in the word of joy, being in there. That's not just being happy or did your child or you have a good day. You were very clear, and so is Team Texas, about bringing joy and hopes and dreams. And you gave such tangible examples of how to actually, move that into a plan of care or into a work group and multidisciplinary, and how you talk through and make those things and group around shared needs that are there, and the challenges that the system often puts on children and families, not necessarily the burden, quote unquote, that's placed on us by our child and the medical complexity. It's often that navigation of the system, and how do we have those burdens of the system right next to joy and hopes and dreams, and how it all can really happen. So really awesome stuff. All right, so now the baton has gone to Texas, it's come back to Virginia, and now I'm going to the Midwest, to Indiana. Christine Hennessey, please take us away.
Thanks so much. And just kind of giving a disclaimer here that I'm actually at another conference to present this afternoon. So apologies if there is background noise. I'm trying to kind of manage that myself. Just a little bit of background about me. I joined the CoINN team for Indiana in year 4. So I was definitely late to the game in terms of the work. I did my best to catch up. And so a lot of what I talk about today is going to be just how to cover that ground, get up to speed and have a place on the team, and keep the momentum of the family engagement alive as we were shifting into long-term support for care coordination and then discussion on sustainability. So we can go ahead and get started. I looked a lot at what it took to kind of make sure that my seat at the table was established, if you will. So Drew, we can go on to the next slide. And these foundational elements were really, I kind of tried to give a good word for each of the things that I really put into action. So for me, it was really important, number one, to focus on preparation. 3.5 to 4 years had passed where most of the team was pretty familiar with our project and had kind of established who did what and how to work together. And so to have the family leader shift, it felt like it was really important just to be able to represent that model in a way that we wouldn't lose our voice at the table. Maureen talked a little bit about being careful not to shift into an advisory role, but to really be involved and be active. And so for me, I had to know what I was talking about in order to be able to really maintain that. So a lot of catch up, a lot of sidebar conversations just to make sure I really understood the project. Personally, I'm the child of a parent with a medical complexity, about 30 plus years into a diagnosis process or looking for the right diagnosis. So a lot of my youth and adulthood has been spent in that realm, as well as the parent of a child with a neurodiverse diagnosis. So I knew that I had a lot to offer, but I didn't know what that was or how to really identify that, relay it to the team without understanding this project work. So the next thing I really tried to focus on was just consistency as I was learning, to make sure that I was engaging, but that I was engaging in a way that was allowing the space for the other team members to continue where they'd already started. A lot of times as a family leader, we have so much we want to say, and we know, that it's important, but to be able to share it in a way that that flows with the rest of the work that's happening was important for me. I felt like in groundwork and remaining in the forefront of these discussions and development. And with that, then looking at with what I wanted to share, how can I say it in limited language to where I, have a tendency sometimes to want to make sure I'm understood. So I say lots of words, and it kind of sometimes helps. Sometimes it makes you more lose the point. So really just focusing on what I'm sharing and letting that speak for itself. And finally, then the confidence that just because I was new to the team, it wasn't, an inability then to contribute as much as maybe someone that was there day one. So really just that laying that foundation for me was important to kind of moving into that collaborative role and maintaining that partnership and that relationship. Even if I was new to the team, we as an organization had been present throughout. So the rest of kind of what I focus on is more the curriculum development within that care coordination model. So having a seat at the table wasn't going to be enough. We really wanted to make sure that we weren't just advisors, but that we were developers. And so moving on, we, Drew can go to the next slide for kind of what those action steps looked like. Cara talked a little bit about the FESAT early on, and we knew that within our funding support for the CoINN project, both through the project work and through Title V, that we had deliverables that we had to meet, but meeting deliverables wasn't going to be enough. We wanted to make sure there was really a value add when we're talking about that whole child, whole family experience. So in those FESAT meetings early on, there was a lot of discussion around some of the things that care coordinators were really struggling with. Some of those being just, we know that there's information that's necessary to a shared plan of care, but how do we ask families about things that are really uncomfortable? And so from there, we started talking about these trainings that we knew we were going to need to put together, and how could we plan those in a way that they were going to be meaningful, that they were long-term, not just focusing on the immediate need of the project or the reporting, but really how are we going to support care coordinators to partner with families and to become a trusted resource for families so that that experience could be meaningful, so that we are taking some of the work off of the family and really making this a successful project that can kind of lead to a long-term support system. So within the planning, we discussed a lot of these barriers, like I said, and within that, then for me, I had to kind of turn to, what do I know? I have prior to the role that I was in and I'm in now, I spent probably the majority of my career doing Medicaid waivers. So working with a lot of individuals with a variety of complexities, having those open conversations about the experiences of being a case manager versus a family member, and kind of looking at those through both lenses and seeing where those contradictions could be assumed. And then how do we get past those biases? How do we get past the things that we know are hard and move them into action plans? So from there, we started to really build on our series of training. What does that need to look like, and how can they go together? We knew that care coordinators could always benefit from more knowledge about Social Security systems or eligibility for Medicaid or some of the different socioeconomic barriers that families face. But how do you even get to those conversations with families if you don't really understand the family experience beyond that clinical setting? So we talked a lot about, not only having those conversations, but then what are we going to do with that information once we have it? What's the point of having a conversation and asking the hard questions? And what is the family going to experience differently once they've shared that information? So we kind of moved on. And when I do wrap up, I'll kind of give a little more detail of what some of those curriculum topics were. But for now, really, we spent a lot of time just focusing on, let's build a whole series instead of one training at a time. So within my delivery, typically I prefer a small group setting, which is great for this project because we had 3 care coordinators from 3 different pediatric clinical offices in different parts of the state, 2 being more rurally located and 1 being more urban. So we knew that the trouble that the difficulty that a care coordinator in one office had or one practice had might be completely different from another, but there's definitely some relatable discussion that could translate across discussion. And I really felt like it was important that we were able to just have discussion amidst our training. So in concert with the support of the nurse that was overseeing the care coordinators, and then also the social worker, we were able to really look at all of the different components of this project work and how to really develop the care coordinator role and give them the support they need to see success and to be able to really understand what we were trying to help them with or help them learn. And delivery was really important. I'm not by nature a professor or medical professional. And so it was an interesting perspective in talking about, what do we already know? What would a nurse care coordinator have already been trained on via their education? And let's not worry about those pieces, let's worry about really talking about the experience and the things that they don't learn in a classroom setting. And so in that similar frame of mind, we also talked about how do we deliver in small groups and in open discussion where there's, formal presentation, but plenty of time to debrief and really talk through some examples and some situational role playing. After each training, then we took time to reflect. We wanted to make sure that we were spending time and allowing space for care coordinators to give us feedback. What trainings helped? What discussions helped? And where do they still feel unsettled about their work? Is it a matter of, we've given you support and we've given you the okay to ask something that's hard to ask, and kind of guided through the process of what that could look like, and maybe some again, role playing through, let's talk about that conversation and how it might go and how it could go differently if you use this word, not that word, or if you're prepared in a different way. But we wanted to make sure that when the care coordinators walked away from each training, that they were really able to give feedback on how it helped, and also where they still see room for growth or an interest in more professional development. So as well, we would then report back to our larger group and have discussion with our leadership, our advisory team, to see how the physicians might be experiencing the change in approach from a care coordinator. Did they feel like after those trainings, there was a difference in how their visits were going with families because the relationships were growing? Or did they feel like there were things that maybe each individual care coordinator might benefit from differently, that we should do some one-on-one? So then some of our time was spent just talking about plan development and looking through, with one care coordinator, maybe at a time, some of the work that they did and where they felt like they had difficulty really getting to the next step of that shared plan of care. And ultimately then, we looked at the growth model. So what was going to come from that? Is the child experiencing, improved outcomes like Maureen was talking about? Is the family feeling like they have more work to do or less work to do? And how are we then informing what we want to do in terms of a growth mindset? As the project is nearing an end, there's always conversation about sustainability, about what the next steps are, if any. And a lot of even my experience on some of our leadership calls for family leaders within each of the states talked a lot about, are we going to have a seat at the table? In different states, we're feeling, kind of differently depending on how the conversations were going within their teams. And so for me, being, again, so late into the work, it was really important to me to be able to make a difference, but then also to really look futuristic. What is this going to look like long term, and what's our legacy going to be within this work? So moving forward to our next slide and talking about that long-term planning, we wanted to really think about the impact. So as a team, I was fortunate to be able to share, my feelings as far as what are we doing with these shared plan of care? Does everyone need to see all of the information, and how does a family feel about a plan being shared, openly? Have we had those conversations? And do families even know that the care coordinators are getting training from family leaders? And let's make sure that they do. And let's make sure that we incorporate them into our planning as well. So it's not just my voice or my team's voice represented at the table, but can we get feedback from families? And so we did. In our surveys and in communications with families, we started looking at the barriers that they felt, where they feel like they keep, seeing improvement, and where they feel like they're getting stuck, and then talking to the care coordinators. One of the things that we focused on a decent amount of time was turnover. We'd get pushback from a care coordinator that engaging with the F2F is just one more family or one more contact that these families are going to have to engage with. One more time they're going to have to share their story. And so we would then talk about how that partnership could look differently, and how much there's an important need to just build that credibility with the family, because we know there's going to be turnover. In my experience with this project, we've had at least 2 changes in care coordinators where we've had to bring new people on and start the project work where someone else left off. And we know that that's just a natural progression of the kind of work that we're asking of the care coordinators. But at the same time, that doesn't mean that the families need to restart every single time. How can we make it easier, and where can the F2F kind of help meet those families where they are and ease into a transition with a new care coordinator. And also, how can we train care coordinators who are new to learn what resources they have available to learn about the family and the experience in a way that they can build that rapport and establish a relationship without requiring the family to do all of the heavy lifting. So we then looked at the expertise. Where do we have team members, and how do we want to use each team member to really inform a long-term curriculum? So if we're going to build, and if we're going to be in conversations with our state Medicaid offices about expansion, which we are, how do we want to frame that curriculum so that if we do start expanding, we know that we've built off of the successes, and we've also evaluated where we've struggled and who are the experts that we have access to really be able to put together a program that's going to work, that's going to help the physicians, that's going to help the care coordinators, anyone that's going to be involved with this family and this child. How can we make this curriculum mesh well? And so kind of in natural progression from there, it grew into the value, which again, Maureen talked about a little bit as well, in looking at not only the worth of the input and the advice that is received from family leaders, but also let's talk about our engagement in the work, our long-term involvement in the work, and the value that the family representation adds to the experience. And so we're looking at that in terms of surveys and outcome measurements, but also just in terms of what's the value to the family that's involved, whether it's, me as a representative of an F2F or a family that's in the care coordination project that has a lot of information to share. So how do we engage families at all levels in a way that they're comfortable sharing their stories and that their value is represented in terms of, if we're looking at reimbursement, we're looking at reimbursing the family. We're talking about the standards of compensation. Family Voices National had a guide that I was able to share from 2021 that really it's not just about how much how much a family should receive so much as why there's value there. And let's talk about it. And let's talk about the things that might be difficult to navigate in terms of a payment model. And let's talk about the things that really improve the program as a result. And so obviously that progresses into sustainability. We can't build the entire curriculum. Again, I'm not a medical professional. I'm not in the practice meeting with these families. And so I'm not the individual by myself to write a full curriculum. Let's talk about where the family leaders need to be involved and where they need to be introduced and at what timelines and what points these different things should be addressed so that it's not after the habits have been established, or it's not after the work has been learned. We're not an afterthought to the process. We are the process. And ultimately the families informing that process is really where that long-term sustainability, growth, value, where all of these things where we really would start to see those outcome measures. And so that's kind of where Team Indiana is in the process right now. Is, we've got our curriculum and we've talked about and developed the different things that we know were important to the project work. But now as we shift from project work to putting these things into practice long-term as billable services, what's that going to look like and what's going to be different? In talking to Medicaid, we know that we need to address the cost and the value add. Reduced visits to the emergency room, for example, not only save money, so Medicaid is happy and we're not paying as much, but also, the child's not going to the emergency room and being exposed to whatever else and being disrupted from their life and their routine and, being pulled away from more tests or more treatment when we could have just looked at this as a more comprehensive model and talked with the family about the different things that they need support with to avoid those costly trips that maybe could be addressed in practice if we really had the right information and the right discussion. So it's definitely not a finished process and it's not going to be a perfect model, but that's the whole point of the human experience. And so how do we just make it the best that we possibly can? And how do we constantly reassess what we're doing well and what we need to develop? And then finally, Drew, if you want to go to my next slide, I promised I'd touch on some of the curriculum. So asking the questions really, just in brief, had to do with, if grandma is the primary caregiver, we're not sure about mom or dad. What do we need to know and what's not pertinent to the case? And, where can we navigate those discussions without feeling like just another representative of the system, or, the person that's then going to be the social worker calling, child protective services and getting them involved because mom missed too many appointments. Let's talk about the transportation barrier. How can we make this easier for families get to an appointment instead of making an assumption that they're being labeled, non-compliant when really there's something going on that could be addressed. And so we talked about how to approach those questions in a way that that families can feel engaged and feel safe to really share what's going on without judgment. From that, we found that one session wasn't going to be enough. And I think it was pretty obvious ahead of time, and we knew, but we supplemented that with a follow-up that was really more Q&A, talking through some of the situations that are being experienced in the varying communities. And, I mentioned before that 2 of our practices were in a more rural setting, while one is in a very urban, downtown Indianapolis. And so for us, it was what's translatable and what's really specific, and how do we navigate regardless of location, and how do we get specific and really take into consideration what's going on in that community that's causing barriers and that could be available to improve the system. I spent a lot of time and get on a soapbox quite a bit in terms of family leadership in general, but we did a presentation on the intersection of the F2F and care coordination in terms of just talking about what's duplication of work and where is the family experience and the connection to a family representative going to give value and support to the other families. And so we really wanted to emphasize that the care coordinators aren't alone in trying to take on their work in a vacuum without the supports that are already available, and without consideration for that family experience was going to be, a good indicator of burnout. So how do we make sure that these different things are available and that the care coordinators know that we don't expect them to be an expert on every single topic, on everything about Medicaid waivers, on everything about accessible equipment and adaptive equipment and how to get those things paid for, just some examples. And then we did a partnership presentation on trauma-informed care, myself and the social worker on the team. And it wasn't trauma-informed care in the way that we're seeing things presented now so much, as we did define, and we did talk about some things that are pretty consistent in most trauma-informed care trainings. But we really developed that model to include the family engagement and defining what the family experience is, or kind of the other side of the coin, if you will, little pun intended. But when we're talking about what we need to develop and how the perspective can shift when you're really considering what's going on for the family and what their point of view is based on what they've experienced historically, maybe personally, what mom went through as a parent or when mom was growing up, and also what the child is experiencing, talking to the child and getting to know them and to understand maybe where they're struggling, so that those things can really be identified and viewed in a more holistic approach. So my last slide is just questions, and we don't really need to go to questions now. I know there's more to do, but I also wanted to share information because I'm happy to give more offline as well for anyone interested. So Cara, I'll kind of direct back to you.
Awesome. Christine, that was so wonderful. I feel like you also just gave this like lecture about what quality improvement is without using all those QI lingo of, we did a PDSA cycle here and there. You just illustrated the constant and really thoughtful, intentional shifting, like the nitty gritty of, what do we need this curriculum, and how do we as family leaders who are not clinical, experts, we're not nurses, we're not MDs or whatever, what do we have to contribute to create this curriculum and deliver it with social workers, with others, to nurse case managers, and the constant shifting and responding to these needs of these families of children with medical complexity that, it's always shifting. So that was just awesome. All right, so now what we've all been waiting for, the wonderful Dr. Cruz. And what has Team Alabama done in this CoIIN? A lot of really great stuff. Take it away, Dr. Cruz.
Thank you so much. I'm Dr. Ladonna Cruz. I'm from the University of South Alabama, where I actually did my internship and trained further with my residency there. And we have a lot of medically complex kids. It was one of my passions from the very beginning, just seeing how families navigate the system. Their strength and their resilience has always been something that's been really important for me, and something that I stress with my residents that are in training, just to see how families navigate the system, and sometimes in very complex ways. When we started this project, Joe, you can go to the next. We were actually doing another project with the whole state and had all the stakeholders. So it came at a very fortunate time that we had people from all across the state, from all different areas. And we were looking at particularly for complex kids in our area, trying to figure out what we needed to do so that we could financially sustain within our state, making sure we had the resources that were available and that were needed for these families as well, and trying to help providers also be able to understand what resources were available. And so when we first started with a definition, and I know Cara has already told you the definition overall, but that was something we really wanted to kind of hone in on so we could see what we needed to do from a cost effectiveness portion for the initial project portion. And what we ended up seeing is that there are about 50,000 kids in the state of Alabama that meet the definition of medical complexity. Probably more, I would say, if mental health was included the way it should be included. But sometimes that doesn't go where we can do ICD-10 codes that actually would put them in that classification. And what we further did is actually looked at our more medical complex, the ones that have more cost for care. And what we ended up seeing is there was about 5,000 patients in the state of Alabama that met that qualification. Interestingly enough, the patients were positioned in the state where the lower half of our state actually has a more predominance of those patients than even the upper half. And so we got involved with this because the grant was actually funded through our CRS, and CRS was at the table with all the stakeholders, and we were talking about these patient volumes. And in the state of Alabama, we have two major universities. We have University of South Alabama and Children's of Alabama that take care of these medically complex kids. But we have a lot of family practitioners, a lot of pediatricians, and med peds that take care of these patients. Without those, subspecialty services always locally available. And in discussion with it, we actually started looking around the state, and the two areas that had the biggest predominance of that population, we started talking about what would be good for our state. Interestingly enough, before this project started, we didn't have a medically complex clinic anywhere in our state. We have a lot of different subspecialty in the University of Alabama or Children's of Alabama that has, particularly with the specialty, but not anybody that has really like a medical home as far as pediatric family medicine or internal medicine pediatrics based. We knew that we had lots of kids that met the classification. And so we ended up saying, how are we going to put this down so we can actually do this project well and be able to serve those that need our assistance most. And so we defined ours as children with congenital or acquired significant chronic medical problems that have multiple organ systems. So they had to have two or more organ systems involved. And we had about 900 kids in our clinic at the University of South Alabama, in our faculty practice and our resident practice. And what we ended up seeing with that is we decided to hone down just a little further and do those that had functional limitations like wheelchair bound, those that had healthcare needs that were more significant, were device dependent with a gastrostomy, tracheostomy, colostomy, vesicostomy, and other devices that we would see. And then, of course, our ventilator dependent children as well. What we ended up doing with this group is we got together and started talking about what was important for us. We had multiple meetings in person, some in Birmingham, some in Montgomery, and then went from there with our team. We ended up having our complex care clinic, which actually opened in January of 2019. Like I said, we had been wanting to do this prior, but felt very empowered with all the support among the state and all of our stakeholders to be able to do this at the University of South Alabama. And currently they're trying to do similar in Birmingham as well. So that's our goal, is to have this not in just our 2 locations that have a lot of the subspecialty care, but have it all through the state. And we'll talk about that right toward the end of the discussion. Interestingly enough, medical home, what is a medical home and define, and there's definitions that have been out there in the community, but what we wanted to do is what a medical home was. It used to be really thought of as a patient, the family, and the medical provider who was actually providing care, but it's well beyond that. And we know that it has to be the whole team. It has to be from the front desk to the person doing vital signs to the person coordinating referrals, and it needs to be all. So what we ended up doing for our initial portion of our clinic is doing more of a culture training and what is important and such. And so we had a family group that would talk to us about things that they needed, things that would help them out with the clinic, and go from there. And that's where we started our project. CRS was actually very helpful for us in getting us a care coordinator. We have a huge practice of 20,000 patients plus, and we didn't have a care coordinator. Our providers were our care coordinators, and sometimes that's very inefficient, as families sometimes can tell you that our duties a lot of times pull us in multiple different directions. And so not having somebody in that position was very difficult for all. And I think that's where it's been a problematic for many years, with not being able to have that kind of care coordination in our clinic and among the state. And we ended up having a team that actually was hired. So Suzanne is actually, Robinson is our liaison, and she works between the clinics. She's actually employed by CRS, but is housed in our area. So her primary site is in our area as far as for our complex clinic. And she does CRS for their specialty clinics as well. We had a nurse practitioner, was able to hire one pretty immediately, and very good process with that. It was a very motivated person that understands very well. Was one of our PICU nurses, and actually got a nurse practitioner and became very interested in it. And her goal was to keep people out of the PICU. And so we had her rotate through with us. And what she was amazed to see is a lot of the kids that in our NICU that she thought always came to the hospital. She realized that this was something that was just, few and far between, and how these kids did well in the outpatient setting, and lots never required hospitalization. And so that was her primary goal, is being able to see how we could help assist families so we could avoid ERs and avoid hospitalizations, PICU, or on the ward service. I've had one of my partners, she's actually part-time with our chronic needs clinic and works in the resident clinic as well, Dr. Bradham, and she was involved from the very beginning as well. And we had our whole team, so we had other persons that were in our clinic that learned a little bit more about complex clinic, as well as taking care of the siblings that were not complex. And that was important to me, because I wanted the medical home for us to be a whole family home. So it's not just the complex patient and the parents have to go elsewhere to seek attention for their other children. But we wanted to have a ground so we could have all the children in the same area. So we started our process. December was one of my first big meetings. I was not involved at the very get-go, and joined about 6 months into it. And then we knew that family engagement was one of the big areas that we wanted to participate in. And we have never had a parent counselor in our clinic. And so we knew that was something that was real important to us. And so we ran that portion initially, just getting a needs assessment, having several families that we felt confident, ones that had required hospital stays for long, lengthy periods of time, and those that hadn't. And we had also wanted foster care involved. And we are fortunate in our process. You can see our timeline. Drew, I think it's probably 2 more slides into it. That's our whole team that was involved in our CoINN. Go ahead. And we were fortunate that we had our team leaders who have been with us through the entire CoINN process for our family leaders. So we actually had Susan Colburn and Vera Spinks that were our glue. So most every piece and part changed besides them, and they were our sounding board. They were our leaders. Among the leading portion of it, they were the project leaders in addition, and we were very pleased to have them to be able to be on our team. Not only are they known nationally as such, but they've always done great for our state and been involved. So our first thing was actually seeing who we were going to have in this practice. And what we did is we decided that we would do our CRS, who was involved in CRS and involved in our clinic. And so we had 142 kids right off the bat. And then we decided what other persons we would have in our clinic. Sure, you can go ahead. That was our full timeline. Go ahead. This was our first part of our patient recruitment. Go ahead. And so in CRS, they actually looked and saw who our patients were and decided that those were the ones that they would choose. Go ahead. And we would look through and see the ones that met the criteria for device dependence. EHR is one of those things that you think would advocate very well with using ICD-10 codes, but doesn't always alert to every patient because if it is a 10th diagnosis, it may not show up on any data that you can have. And so sometimes gastrointestinal dependence was one of those things that didn't show up. Go ahead. So it was ideal for us to have this. You can see this is a picture in our area. CRS is the building that is right beside the Strata building. CRS is the green top building, and ours is just right across the street. And on the other side of the street is our children's hospital. So it was an ideal place to start for our state, looking at medical complexity and how we can make a difference with our CoINN. So go ahead. Our second part was our family engagement. And like I said, go ahead. We had a great team structure, Susan Colburn and Vera Spinks. After we had our initial parent council meeting, looking at what we wanted to do, we wanted the parent we wanted Family Voices to actually assist in helping us learn what we needed to do overall, helping our families understand the importance of the family engagement. And so we had that conference as well, which made a big difference for us as in addition. Go ahead. Our third action plan was to get a shared plan of care, and Suzanne Robinson actually helped us with this, was kind of the lead portion and continues to be the lead portion in this. And it was determination of what was important. You can go ahead and skip 2 slides. So we looked at a shared plan of care. So initially they had the provider do that, which we know that's probably not the best person. So the medical history, we decided, if you look at our shared plan of care, this is the one we're currently using. Go ahead. It changed very differently all through the time frame, but what we ended up seeing for us with all our determination with our families, with our family leaders, and our whole group is what's important to families is this little section we have here. Go ahead. And it's that is get to know me section. So what the nicknames are, what their favorites are. This became really important to us as we started talking with families, because a lot of times the families were worried about making sure they had all the medical portion there, which is easy for us as providers and our care coordinators to place. But what we wanted to make sure we emphasized is who are the, what was important to the families. And this is what we saw be something that was beneficial. And we try to include this. It became the bigger structure, and then go ahead, as well as the goals. And this is probably something we didn't do as well a job as we needed to do in our clinic. We always talked about goals and such, but we really never made the families give us what their goals were. And this has been the biggest thing that's been so helpful. As a provider, sometimes communicating, I always would want to communicate what my goals were, but that may not be the best thing for that family to hear what my goals are with overall care without knowing what their goals were. And so having this team approach has been such a great thing. We had a patient just recently who came to our practice, and I didn't ask could I use the photo in the presentation, so I didn't include the photo, but it was a family new to us that's been in our practice since February. has been to several different providers, and has had care issues along the way and communication issues along the way. And so this was the first time she had been to our clinic. And I present this, we have lots of information we need to know about them. But I asked her from the very get-go, what are your goals from changing clinics? And I think that at that point, that was something that a lot of times was not said, but I think it's important to say when you meet a family, is to actually get that information out front. And her goal was to be able to have time away with her child on a family vacation and such. And it took her about a month to learn how to plan that. So we talked about different things along that way. And the mom was very motivated, and they made that happen. So about 2 weeks ago, she sent me a picture of them at Dolphin Island and showing him at the beach. And it was his first time he'd actually been to the beach at 10 years of age. And that's the whole part of this project to me with that shared plan of care, is making sure that we know what's important to families and we be able to work toward those goals. We need to keep their strength and resilience going. And without meeting their goals and expectations, then that actually becomes a part that we, fail with as medical care providers. And so that was something that was real important. So family engagement with this project, putting it first and foremost, has made a whole difference for us as a medical community. The family is part of that medical community. And I think that was when the medical home definition was made, it was more so the care team, but the care team 24/7 is that family. And so that's something that's very important for us to see how we can make things better for that family. One other story that I will share with you was a person who was in our state and was actually going out of state and talked to she was having a procedure done and needed anesthesia. The goal for her is to never have a tracheostomy. That is their desire. That is part of their plan long-term for her health. Is if that's required, then they desire not to do that plan. And so the mother had gone to another facility and had at a different state and talked to them. And the mother asked, the person said that she's going to be intubated immediately. That was the decision that the medical provider had made, the anesthesiologist. And the mother said, we're not going to do that. This is what I need. You need to be able to give me these, be able to assure me that we're not going to have to be intubated. I don't want a tracheostomy. I have fear that if she gets intubated, that she will not be able to be extubated. And I think it caught the anesthesiologist off kind of caught him off guard initially. And he said, why would you say something like this? And she said, because my medical home made me that way. And she said, I could express what I need, and I could tell families, I could tell as a family what we need as a family and what's important to us, and that our story is different than everyone else's story. But I need you to know my story, and I need you to know that she cannot be intubated for this procedure, and we'll have to cancel this procedure. Otherwise, if you can't guarantee me that you'll make sure other ways are adjusted. And so, she shared that story with us, and it's something that we want to make sure that we're able to do for all families and such, particularly our families with medical complexity. Go on, Drew, thank you. Next slide. So we looked at all our different things, and basically our three things we came up with: partnership, innovation, and caring. And that's the goal for our medical complexity CoINN. The results that we had was that families actually identified and actually had a shared plan of care, where we had 0% from the shared plan of care. 50% actually identified and said that they had actually used their plan of care in another facility. Improved communication. And this is something that's really important to me. Several of our families have said recently, and this I think is where the medical system fails so much, is people fail to communicate. They fail to communicate information about standard procedures, complications. They fail to communicate lab values because they don't feel like people will understand or need to know, or feel like that they will be overwhelmed if they know all the information. But one of our family members just recently said to me, thank you for not listening, but not just listening, but actually hearing. And that's what a medical home should do. And that's what providers should do, And I'm hoping we can encourage that for all of our families to feel long term. And improve quality of life. With our survey, we actually saw that during the CoINN that we had a pretty significant increase opinion from the families that we were trying to improve their quality of care. And that's what our team should do. What we want to do long term, go ahead, Drew, is be able to spread this not just to our little area, but actually spread it throughout the state. And we have the stakeholders, we have the people that are invested, and we have great family leaders, and we have providers that just need to feel comfortable a lot of times with this communication process and such, and getting to understand the families and what they need. Go ahead. So where we are right now is we have 14 CRS areas within our state, and what we're trying to do is find and locate medical providers that will be able to learn from what we learn from our mistakes, learn from our barriers, learn what worked for us, and so that we can spread this throughout the entire state. We don't want to be just a little star on the bottom in our Southwest area. We want to be able to go all over the state. We have 4 groups so far that are interested, and the Florence area has expressed interest. Montgomery has expressed interest. Children's of Alabama has expressed interest, and Dothan. So we will be able to cover a lot of portion of our state. But our ultimate goal is to be able to have this long term, so that we all are able to benefit from this, and mostly our families. Go ahead. So children with medical complexity do require healthcare needs that aren't easily met, but a lot of times things can be met just by asking the right questions. Care coordination is an important part, and it takes a team approach. We always laugh because Suzanne Robinson now is when we ask families, they say she's our best friend, and it's true because when they're in time of need, they know where to call, and they rely on her heavily in our clinic. It's been so good. Family engagement is important. We can only know what families want by engaging them and having them be able to have a voice. We can only help them feel confident and empowered enough to continue to advocate for their kids and keep that strength and that resilience going with us being able to have that communication. Go ahead. Using a shared plan of care a lot of times helps to know, but without having that personal component of it, of what's important, we see this time and time again. Having that, we've always talked about having that when they're in the hospital, taped on the edge of their bed, so they can actually refer to that when they walk in the room. So families are able to express, even if they can't verbally say. Families need to be able to express and be able to have something there that's important to them, so that they know what's important as a family group, as a family unit, and know about that patient. We've had personal experiences within our team from our persons from our family engagement that expressed how important they feel like this shared plan of care is. And I do value it well. We're still trying to make it more portable, and that's something that's been a little bit more difficult. But we hope to be able to do it. Right now we have it on paper, but it definitely needs to be electronic long term. And our primary goal of quality of life is to provide options. And, for that family that was able to express how she felt, that's what we want to be able to, everybody be able to do. And for them to know that they have a support team that's there to do whatever they desire. And advocacy for children with medical complexity in their family takes all stakeholders. And this CoINN project that we did within our state is the first time that I've ever been involved in a project that went the entire state, as far as having the stakeholders present, making their voice be heard, and family engagement, which is our most important portion, was definitely emphasized. And it is what kept the glue for us to be able to continue our project. Thank you so much.
Thank you, Dr. Cruz. That was really amazing. And I'll just do one little wrap-up thought and then pass it to Stacey Newman, I think, to handle some questions and some thank yous and all that stuff. I think you did such an amazing job sort of illustrating how Team Alabama and all the CoINN teams really took, I joked in the beginning about, here I go right into the acronyms, how much we love acronyms in health and public health. We love buzzwords too, right? Medical home, shared plan of care, family-centered care. So much of these words have become really adjectives and nouns. But what you just illustrated, Dr. Cruz, was taking that shared plan of care that everybody tosses around a piece of paper, talks about it, right? And within that, the goals, and just showed the little nuance that had this massive impact of moving from my goals to shared goals, and the radical listening and hearing and communication involved in the middle that takes those noun, adjective, buzzwords and really gives them action and flexibility and stuff. So I hope you've enjoyed our sort of trip around the country and landing back in Alabama to hear about, the key role that family engagement and family partnership played in all of this, moving from buzzwords to action to really make change in advanced care for kids with medical complexity. So Stacy, I will hand it to you, another wonderful partner for us in the CoINN.
Thank you, Cara. And yes, you'd mentioned that Alabama's an advocate of the FESAT, and we certainly are, and we certainly appreciate National Family Voices and all the work that you all do. I noticed one question, Dr. Cruz, somebody was wondering about the practice in Florence, expressed an interest in the model for primary care, focusing on meeting the needs of children with medical complexity.
It's Grant Allen's group.
Okay.
West Stubblefield was in that role too, but West Stubblefield is now at ADPH, but it is that practice.
Okay. And I personally have a question for Maureen. Maureen had mentioned the app a couple times that Texas had worked on as part of the CoINN. Can you expound a little bit about the app?
Sure. It's so it's an app for your phone that both clinicians and patients can access. And when you first open the app, the first thing that you see is a photo of your child that the parents can upload. And then the next thing is the About Me section, kind of similar to what you were describing, Dr. Cruz. And we can also we can update photos, we can upload videos, so that the very first thing that a provider who's accessing it sees is, our kid in their natural state. And then we have the plan of care is there. There's a dashboard where parents can enter and track symptoms. So like, last year when my kid was having diarrhea every day, I'm sorry to be explicit, but we're all in healthcare here. But whatever the symptom